Today is a day of great people joining us. We have Professor Lindsay Allen that started the whole field of fetal cardiology. So Rabbi and Alfred, you better be careful because Lindsay will be there to comment at the end of your lecture. Don't make any mistakes. My good friend Rabbi Chavi will talk to us about the small left ventricle.
Yeah, thank you, Kipros. First of all, I would like to thank Kipros for all the friendship all over the years and for also giving us today the opportunity to give an educational talk. Today, Sunday, 26th, we should be supposed to be in Italy, I guess. It was Sunday, it was the fetal surgery day. But if Michael Harrison was for you the inspiration for doing fetal surgery, for me and for many of us, Lindsay Allen was the inspiration. I heard her the first time 1987 in West Berlin, and I heard also Davos, and then I decided not to continue obstetrics, but to focus on fetal ultrasound. I met you 92, Kipros, so in Bonn as the fetus as a patient. So today we'll be speaking on the left ventricle and smallness, and you should also know just at the beginning how to assess the left ventricle. It's not because it's positioned on the left, but there are quite differences between the right and the left ventricles. And one of these, the easy feature, is to focus on the apex of the heart to see if the left ventricle is forming the apex of the heart. On the right side, there is the moderator band found, which was described by Leonardo da Vinci some 500 years ago. Second, you'll find the tricuspid valve, which is inserting slightly lower than the mitral valve on the septum. And you can see, you appreciate this on the ultrasound image, as you know this. Because of the moderator band and the tricuspid valve, you see that the right ventricle is shorter than the left ventricle. And the left ventricle has a more smooth area, whereas the right ventricle has a more irregular area. And if you look at the width of the right ventricle, it's slightly larger than the left. It is in the ratio of 1.2 to 1, but in general, it's almost equal. They are equal size. Now, if you have a situation where you will find a small left ventricle, and you see here how it looks like on a video, keep in mind also to focus on the contractility and not only on the position of the valves, but if both valves are opening and closing. And keep in mind that the blood flow will enter from the atrium into the ventricle, so know that this is the left atrium, typically recognized by the two inferior pulmonary veins. Now, using color Doppler is today accepted as almost mandatory in many guidelines, and this will help you in confirming the filling during diastole, but also have always a look to the outflow tract, to the aorta, and the three-vessel trachea view, but I'm sure Alfred will cover this afterwards. Now, when you have situation like a small ventricle, always try to compare it with the right ventricle. And in general, keep in mind, check up whether it's short left ventricle, which is a ventricle not forming the apex, but almost many cases we'll see are associated with a narrow left ventricle, leading to a disproportion between the right and the left. And if you see such a situation, what can you do? You can call the doc. If Lindsay Allen is the mother of fetal cardiology, Laurent Fermont is the father. So if you try to get them, they will let you know that they are sorry, they are retired. If you send me an email, or to Alfred will let you know, please go to our book table 33 and you will have there many conditions, and then we leave you up to you to find out what kind of diagnosis can be behind this. But we'll let you know that the most common two conditions are aortic coarctation and hypoplastic left heart syndrome. Then you have to rely on your own, and you can use different methods or techniques, and you can ask the wise men, the three men with beard. One is Kypros Nicolaitis, using here extensive experience, the one who have revolutionized fetal medicine, but you will never reach such an extensive experience. Then you can ask Galileo Galilei. That means you will try to measure everything which is measurable, but this will not help a lot in the conditions I will discuss with you, because it will help only for a small amount. And then What I will approach today is the way this scientist did. It is a Persian Arab scientist who worked 1,200 years ago. Many people are using every day, children and adults, in our work and in artificial intelligence, his work, but no one knows him in a way, but we use his merit. I will let you know at the end who he is. So, and this is why, let's start by the two most common conditions, the hypoplastic left heart syndrome and aortic coarctation. And these are the top two. And you should, at the beginning, just know the difference and the common between these two. So I will show you the list, and this is what you should know. The hypoplastic left heart syndrome has a short left ventricle, but the coarctation has a narrow ventricle. And you see all things in yellow are abnormal because the hypoplastic left heart syndrome is very severe. So you'll have the left ventricle does not form the apex anymore. There is poor contractility. The mitral valve is dysplastic. If you use color, you'll see almost no filling. The aortic valve is in general closed, and you will have in the three vessel view a reverse flow. Whereas in the coarctation or suspected coarctation, you have a narrow left ventricle, almost normal appearing heart, and in the three vessel view or in the aortic arc view, a narrow aortic arc. So let us see some conditions. And in another table here, I want to highlight that, keep in mind that the hypoplastic left heart syndrome does not have a VST. So if you have a VST, ventricular septal defect, it is almost never hypoplastic left heart syndrome. It is another condition. So you see here on this video clip, what I was telling you. So you see no contractility on the left side, the poor contractility, the apex is formed by the right ventricle, and you see the echogenic wall typically of endocardial fibroelastosis. On the other hand, the aortic coarctation appears small, even if it's more narrow, but still you see the normal contractility. So keep in mind this normal contractility, the mitral valves are and the tricuspid valve are opening, and this looks like a normal working heart, but the left side appears smaller. In color Doppler, occasionally you see some filling, but in general there is almost absent filling. And when I teach on a hypoplastic left heart syndrome, I tell the persons, please keep in mind, it looks like a heart which will never be able to cover the perfusion of the body after birth. So it's a non-functioning left ventricle. If you compare this condition with the coarctation, you see here, it's pretty nice. The left ventricle is showing a good filling, and this is why I would recommend always when you have an abnormality or even on screening to use color Doppler, because within 2 minutes you have the you can distinguish between both conditions. Now let's compare them again. On the left side, the hypoplastic left heart syndrome, and on the right side, a smaller left ventricle in a setting of a coarctation of the aorta. Or in color Doppler, again, the comparison between the absence of the filling in comparison with the normal filling of a rather slightly narrow ventricle. While in hypoplastic left heart syndrome, it is almost diagnostic, these images. For the suspected coarctation, is only the first step. And you need then to go to other planes. And the most important one is probably the three vessel trachea view, where you see the pulmonary artery and the aorta side by side. And in a coarctation, you have a similar image, but with an antegrade flow in a rather narrow aortic arc. While in a hypoplastic left heart syndrome, conversely to these other two, there is a aortic arc which you cannot almost see on 2D, and you see mainly the reverse flow in this setting. So this is a very important plane, but even this plane you are not having the diagnosis. This is why you need to get a sagittal view to confirm for the coarctation the narrow isthmus with the antegrade flow, and this shelf, which is also typical for the coarctation. So the coarctation, you have a suspecting in the four-chamber view with a narrow ventricle, you get a three-vessel view, and you confirm in a sagittal view. And this is how you can distinguish both of these. But this is not all, because you may have also other conditions which may also present with a small left ventricle. The next step you should do is check if there is any septal defect. For septal defects, these can be small, they can be moderate or large, but also they can affect the AV valve being part of an atrioventricular septal defect. If you see a moderate to large VST, in general, you may expect also to have a small aortic valve in some of these conditions. Consider the presence of a severe aortic coarctation with the VST. In general, it's more severe than the one without VST, but it can be also an interruption of the aortic arc. So both conditions associated as an obstruction of the outflow tract of the left ventricle. But also it can be a double outlet right ventricle where both vessels are arising from the right ventricle and the left ventricle is small because the whole blood will go automatically to the right side. So you see here is an example where you see a VST in the four-chamber view and you see the narrow left ventricle and moving to the three-vessel and trachea view and expecting to see a narrow aortic arc. You don't see it, and you don't see neither a thymus, and this condition is an interrupted aortic arc, and the chromosomal examination showed a 22q1 deletion. Or in this case here you see the discrepant size of the ventricles with an outlet VST, and getting to the three vessels, you see the double outlet right ventricle with both pulmonary artery and aorta arising from the right ventricle. So these two conditions are quite possible and common, and the severe coarctation. But also, I told you the AV canal, the AV septal defect. AV septal defect, this is what you know in general, but let's say in 10% of the cases, you may have a smaller right or smaller left ventricle, and this is what we call an unbalanced AV septal defect. The good news, it is less commonly associated with abnormal karyotype. The bad news, it is more associated with more severe outflow tract anomalies like coarctation and others. So this is a condition you should seek for when you see a discrepant ventricle with the VST. And you see some, one example here, you see the discrepant size of the ventricles, but associated with an AV septal defect, and this is how it looks like on a video. And on color Doppler, it may be more impressive because you see the narrow ventricle. Sometimes you even have difficulties in seeing this ventricle when there is an AV septal defect, but the gap is often so large that you can recognize it. So these are this condition. Now next, this is some other possible conditions like mitral atresia where you are assessing the valves, but also think on the veins. I told you that the left atrium drains into the left ventricle, but keep in mind that there may be some abnormal venous connections you can find on the lateral or on the posterior wall of the left atrium. And the most common one is the left superior vena cava. The left superior vena cava is found in 1 out of 300 fetuses. We did a study where we showed this frequency and confirming other studies. But in some of these cases, it is associated with the narrow left ventricle. Some theories say that the left superior vena cava is in a way obstructing the inflow leading to this view. But also keep in mind that it is also associated with the coarctation of the aorta. So when you see in discrepant chambers, as you see here, look at the atrium, whether there is here some structure looking like a cyst, as you see it on the border of the left atrium, which is the typical condition of a left superior vena cava. If you see it in this discrepant setting, consider that 20% of the cases are associated with the coarctation of the aorta. And you see here a video showing this. This is something you see only if you are really looking at. So keep in mind, when you see the discrepant ventricles on the border of the left atrium, you may see a less VC. Or here in color Doppler, you see how the flow coming into the left ventricle appears slightly obstructed, but this is probably not the reason. We don't know the reason why. But the combination of discrepant ventricle size plus left superior vena cava increases high the risk for having coarctation. And the other condition is the abnormal lung veins. So when you look at the posterior aspect of the heart, you see the two inferior veins, as I told you before. But in some conditions, when there is an abnormal lung vein drainage, conditions which are really very difficult to detect prenatally, and in general, most of them are missed. But if you know the hint, it can be also a narrow left ventricle. There is a confluent vein behind the heart. This case we had, when we were diagnosing this, difficulties in getting the diagnosis. We saw disruptant ventricle, but we did not see any narrow aorta. And then looking more carefully, we found behind the heart this region showing that the right and left pulmonary veins are not entering the left atrium, but entering a confluent vein. This is why I added this condition to the short list of after coarctation to look at, because we don't look at them regularly, or we may forget them. So keep in mind, also consider the abnormal lung vein drainage when you see disproportion. Or in this case, you see both veins are entering the right atrium, and you see here the narrow left ventricle in comparison to the right ventricle. And I come to the last case, and I put an interrogation question here after behind the small left ventricle, because what you see here appears to be a small ventricle, but what my message to you in this case is think outside the box. Why I'm saying this? Because what we are seeing here, you see the ventricle on the left side is short, because you don't know if this ventricle is the left ventricle. You see the ventricle on the left side is short. Why I'm saying this? Look at this condition. Under normal conditions, I told you before that the left atrium drains into the left ventricle, but there are conditions where the ventricles are inverted. So you have the right atrium with the left atrium, but you have attached to the left atrium the right ventricle, anatomical right ventricle, and the left ventricle is attached to the right atrium. This condition is called atrioventricular discordance and typically found in corrected transposition of the great arteries. So if you look at, again, this condition, you will see that the smooth left ventricle is still forming the apex of the heart, but it's now on the right side. And with what you are seeing here, small, appearing small, is the anatomical right ventricle having normal contractility. And you see the valve attachment is slightly lower than on the right side. You see the moderator band is on the left. So consider also this the condition of the atrioventricular discordance. So I come now to some rare variants. You have occasionally in third trimester the disproportion you can see, and you don't know if it's coarctation. You see here a funny situation where the foramen ovale have some fun moving to the left and back to the right and again to the left, and associate with the discrepant ventricular size. Lindsay Allen, I remember 88 or 89, published a paper on coarctation saying that in late gestation, the accuracy of detecting coarctation will be 20% due to this sign. This is why it's not reliable, so be careful. It's a rather normal variant. In general, we recommend a postnatal echo, but it's rather a variant of the norm. So I come now to the end. I want to give you the enigma solution. This scientist lived in Baghdad between 780 and 850. He's one of the most famous mathematicians of all times. He was the one who developed algebra. So the word algebra was the name of one of his works. And he did also an approach to mathematics and to reasoning. And his name is Muhammad ibn Musa al-Khwarizmi. He was translated into Latin, and his Latin name is algorithmi. And when you use the word algorithm, and this is why I tried to show you today by algorithm how to arrive, you are using it. If you speak Spanish, the word guarismo, meaning number, is also his name, but he's not known. Pythagoras is known, and Archimedes is known, Galileo is known, but Al-Khwarizmi, who's the founder of the modern mathematics, is not known. And this is why I approach, and we approach our reasoning today with the algorithm. And if you ask him how to approach the small left ventricle, he tells you, first of all, check the apex, the contractility, like a computer, like in future artificial intelligence. If it's no, it's a hypoplastic left heart. If there is contractility and there is a filling, it can be coarctation. But also consider to find out whether there is a VST. You still see me? Yeah. VST, then it can be severe coarctation, interrupted arc, or double outlet right ventricle. And look at the AV valves, because you can find unbalanced AV canal, AVST. You can find mitral atresia or AV discordance in corrected transposition. And don't forget to look at the veins, because LSVC is very commonly associated with aortic coarctation, but also abnormal lung vein drainage. We did not have time to discuss extracardiac situations like volume overload in the right ventricle or diaphragmatic hernia. And then keep in mind that if you don't find anything associated, it could be a normal variant. And when you are working on this, you need always to perform some measurements like Galileo did. So document your examination by performing measurements. And once you have seen all these conditions several times, then you can become wise and expert as Kypros. And I want to thank you. And I want to thank Kypros for his friendship. And thank you all for your kind attention. Thank you.
Thank you, Robbie. Thank you very much. So, Lindsay, challenge him.
No challenge at all. I mean, a superb talk as always from Robbie.
Thank you, Lindsay.
Very clear demonstration of the topic. Sometimes he starts with the most obscure things first, but this time he started at the beginning and he worked his way through from the common things to the rarer things at the end. Absolutely excellent. I know he works very hard not only at getting beautiful pictures to start off with, but he works very hard as he slides to get very good representations and so on. I've sat next to him in lecture, so I know he works very hard on his computer to try and get really good documentation on his slides as well. It's an object lesson on how to give a really well-designed and presented talk, and working sequentially through the data and through the heart to make the diagnosis and being aware of the most common things first, and
thank you
through to the more complex things. But very good images, and the most important thing, of course, that he said was think, and I can't say that strongly enough. When you get the best images, and then think, don't have your brain in neutral and thinking of something else. Think about each step, working through it logically and sensibly, and of course then it's all easy. So it's a great pleasure to see all these old I'm afraid, as old as I am almost, old friends, and hope that at the time talking to lots of you out there. It's a great pleasure to be invited to join you, but I can't criticize Robbie's very clear talk.
Thank you. I'm getting red, look.
Amazing. Okay.
Very nice. Sometimes I'm a bit critical of him because he likes the exotica sometimes, and I think you should start with the simple things, but this time he did perfectly.